World Health Organization. This is about what do we call, or how do we say what is mental health and well-being. So obviously one line definition won't suffice, and these are the different aspects of mental health and well-being. So if you can start from the at the down, you can see the green oval of basic needs, and from there there is an engagement at different levels, then the relationships, overcoming challenges, your purpose in life, your self attitude about yourself, which decides many things about your well-being, and having overall control over one's life. So that's how the mental health or well-being has been kind of a defined, or this is wholesome is what we call as a mental health and well-being. These are the different aspects. Now when you talk about stress, distress, or depression, anxiety, please try to remember this as a spectrum rather than the dichotomies or the compartments. What do I mean by that? That means anyone can go through the stress, distress, depression, or anxiety, and obviously come back to the what we call as a well-being zone or a well-being phase. So this is a very dynamic, in a sense, a spectrum of stress, distress, and common mental health condition. Now, stress, I think all of you know that it's basically the individual's physical or psychological response to a situation which is a challenging or demanding. Basically, this is the definition of stress. That means anyone who goes through any kind of a demanding or challenging situation, be it an exam, job interview, job-related issues, family, relationship-related issues, and so on. Then we all of us have experienced this, which is called as a stress. Now, next point to understand, stress differs from person to person. So it is a very, very subjective phenomena, and you cannot generalize, experience of one stress with another. And last point is, stress is not bad always. So that means, because we feel stressed about job interview, basically we prepare and we go with all the preparation and reading about that job interview and so on. Similarly, like exams, we any evaluations or exams, because there is some stress, we study hard and try to perform better. So that's why stress is not bad always. It can be a positive motivation at some point of time. But when we term, and specific term when we use as a distress in mental health spectrum, then distress always and always has a meaning of negative state. And negative state is because our coping mechanisms have failed to return us to a well-being state or a stable psychosocial state. Now this can happen due to unexpected situation. It can happen because of unhelpful adaptation to the situation, or both can be the reasons. Effects of distress and stays longer, typically for 2-3 weeks. We will just see the symptoms or signs of distress, and remember they stay for 2 to 3 weeks. Signs of distress, as I've noted down here, you can read through it, but largely when anyone goes through the distress, there is some amount of discomfort, there is constant worry, there is different feelings, negative feelings of sadness, anger, disappointment, and so on. Avoidance can be the coping mechanism because of the distress. People may feel exhausted or fatigued. There can be a lot of physical symptoms like headache, backache, body ache, pain. These are very common along with the distress. Your sleep can get impacted, and obviously concentration gets impacted. Overall, you may feel low in interest. So you can't, kind of able to perform well. So these are the signs of distress, and please remember these signs generally stay for 2 to 3 weeks, and many a times people cope with this distress and then they come back to a stable psychosocial state. Now if the distress continues beyond 2-3 weeks, and the signs of distress or the impact of distress continues, then there is a high possibility that people may have what is called as a common mental health conditions, commonly we know as a depression and anxiety. In the common mental health conditions, this is some of the facts that why they are called as common mental health conditions, because they are commonly occurring. They can affect any one of us, so nobody is immune from it. These are the symptoms we experience in our day-to-day life, and they can be of a mild, moderate to severity, any intensity basically. And obviously one can benefit if we, as I said, if we act at a stress or a distress level, there is a high possibility that person will return back. The common question or the common knowledge one should have, that how do you differentiate between the distress and depression, anxiety? The first important point is a severity of symptoms or severity of signs. That means, any symptoms or signs of distress or depression or sorry, distress, if they are very severe, when I say severe, the intensity wise as well as the frequency wise. That means if distress is present only for 1 or 2 days and then next 3-4 days in a week, you are absolutely fine, then that's not the severity. But if you have 5 to 6 days of a week, if you are facing the symptoms of distress, then that's the severity I am talking about. Second important point is the impact on the functioning or the daily activities. So that means if the distress or signs of distress have a huge impact on your functioning or daily activities, then that again suggests that you have already gone into a depression or anxiety zone, and that's an important distinctive point. So that means, in other words, whenever you are in a distress, there is a high possibility that it may not impact your functioning or daily activities, and you will still continue to do your day-to-day activities. The last point here is the duration of signs or symptoms. So again, as I said already, distress signs of symptoms of distress are for 2 to 3 weeks, while as we move ahead, the duration of signs or symptoms for depression and anxiety is more than that. Generally taken, for depression is 1 to 2 months, while for anxiety 3 to 4 months. So that's the duration of depression and anxiety, while for distress duration is always limited to 2 to 3 weeks. So these are some of the signs of depression. Again, I won't go too deep into this. Most of you may know about this. The depression is largely about low mood and different kind of moods, feelings of irritability, anger, crying spells. There is a reduction in energy, interest, concentration, confidence, and so on. There is a reduction in sleep, appetite, sexual drive also. There is a core thinking or feeling process of helplessness, hopelessness, and worthlessness to depression. And again, giving you this background of depression, because when we talk about different feelings about for among people with different sexual orientation, for today's topic, I think it's important to remember these signs. And then ideas of suicide or making plans of suicide. So these are the signs of depression. Similarly, if you can see anxiety, there is a different form of symptoms here. They are different than depression, where in anxiety there is a constant worry and feeling of restlessness and feeling of being on the edge. People experience several physical symptoms as a result of anxiety or panic, and you can see that there are a lot of physical symptoms which anyone can experience when they go through this anxiety. Generally, severe anxiety is called as a panic, and in the panic condition or panic attack, as we say it, there is this kind of a very severe symptom, and people can kind of feel that it is like a heart attack or any other physical condition. In anxiety disorder, generally there is a sleep disturbance also, poor appetite, poor concentration, and feeling of weakness or lack of energy is also there. So this is all about the mental health as well as the mental health conditions. And again, I want to just highlight few points around suicide, because again, relevant to today's topic is there is a high prevalence of suicide among people who have LGBT IQA plus orientation, and there is a generally suicide is a huge issue among India, and we are kind of contributing unfortunately to almost 33% of death by suicide all over the world. So that's why I think suicide in a mental health perspective is very important to understand about suicide. A few understandings, again, not deep diving into it. So these are the common processes or thoughts among individuals who contemplate about suicide. Generally, they are sad, tense, or depressed. These are some of the wordings or thoughts they get in their mind. There is a feelings of hopelessness, worthlessness, self-blame, helplessness, and loneliness. Again, remember these different feelings. And again, when we talk about mental health issues among people with different sexual orientation, try to see or try to imagine or empathize that how people with different sexual orientation from the development point of view, from the childhood, adolescence, getting into the adulthood, how do they go through these different feelings and different emotional turmoils. Again, the multiple, remember always suicide as earlier commonly, kind of a misterm as suicide is because of mental illness, and that's not true completely. Though there is a small proportion of people who have mental illness can basically, die or attempt suicide. But most of these reasons, if you can see, these are social, cultural risk factors or reasons for suicide, or people thinking about suicide, or they are dying by suicide, or they are attempting suicide. And you can see the exclusion, discrimination, or feeling extremely lonely. These are the most common reason in case of people who are discriminated. And again, I think through this course you must be understanding that how people with LGBTIQA orientation are getting discriminated on day-to-day basis in our society over last many decades. What are the protective factors in this case? Again, these are the general things, but basically acceptance, inclusive social and family environment, healthy relationships, having a strong social network, having a job, good financial condition, and so on. So these are some of the reasons as a protective factors. The last point I will just say about myths about suicide, and again, this is a general thing. It is not only related to any class or any class, caste, or religion or anything. It is a general human thing that asking about suicide does not provoke acts of suicide. So there is a myth around in the communities that if you ask anyone related or about suicide, then it will increase their thoughts of suicide. This is not the case. In fact, the research has shown that if in fact, if you ask somebody about suicidal thoughts, then it reduces anxiety associated with these thoughts, and they understand that you are there to help them. Similarly, the second myth is that people who talk about suicide are attention seekers. And please remember, they are not simply attention seekers. Speaking about suicide is a way of communicating distress, and such individuals need to be heard and supported adequately rather than getting dismissed. So these are the few myths I wanted you to just highlight before we jump into the next topic. Now, before I get into this topic of today, and with this 15-20 minutes of a background, I will just want to maybe hold on for 2-3 minutes. If there are any burning questions, if there are any issues you want to ask around this related to mental health, then I would like to answer those first, and then we will move on to today's topic. So I will just wait for 2 minutes. If you have some immediate questions, then I'm happy to answer around the mental health or the mental health conditions which I just described. Yes, Subham, please go ahead.
Shubham, please go ahead with your question. You have raised your hand.
Yeah. Am I audible? Am I audible
Yes.
now?
Yes, you are.
Okay, sir. I mean, what I just
is that I often imagine sort of
things which are related to my death. That is the post-death scenario, and I just kind of visualize those condolence meetings and all that.
in my dream, and also is it something like
Because of some kind of depression that I'm just kind of imagining or visualizing these things.
I'll try to limit it to a short answer. Obviously, this needs an exploration, Shubham, first. And basically, maybe somebody, mental health professional, needs to assess this condition. But generally, this can be, it cannot be a mental health condition. The dreams or what you visualize, even sometimes, is many a times automatic or a random thoughts. It can be due to what you are consuming, like a knowledge or reading about. Nowadays with the media, we do read or we do see many things, and that can be the reason. So that can be one of the reason. But again, this needs to be explored. I will say that I won't want to kind of dismiss this as this. You may need to kind of visit a mental health professional or a psychologist and try to explore about this. Thank you. So any other particular question? Otherwise, we will move ahead.
I think we can go. Okay, there is one question, sir. You suffer
Yeah.
from certain periods of depression which peaks up during crisis and you instantly feel happy once you are out of crisis. Is this BPD?
No, no. So let's not obviously get into the diagnosis, because diagnosis is more, for the mental health professionals. I will say this is not. I mean, you can't say this is any diagnosis. People can go through the phases of depression and come back on their own. And there is a strong data around this, that even if anyone, that's why I said it's a common mental health condition. Remember, always compare common mental health conditions to physical health issues like a cough and cold. So for cough and cold, you don't always go to the doctor, or you don't always, cough and cold, obviously 90-95% of the time may not get into pneumonia. So it's the same thing, like phases of depression or distress can be very normal, and you can come back to the well-being zone. Okay, so let's, I think, go back. I will say, let's try. Ooh, oops, what happened? I just try to reshare my screen. Something happened. Yeah, you can see it now again. Yeah. So what I'm going to do for this session, and I think we have almost one and more than 1.5 hours. I will like you to participate as much as possible with your own experiences about this topic. Your own life experiences through your friends, families. Obviously, you are doing this course, so there is some purpose attached to it, and so on. And plus, you have already had week 1 of this course. You have understood many terminologies. Yesterday also, I think you had yesterday's session was on psychosocial development for among people with these different sexual orientations, so on. So I think I will like you to participate as much as possible, and that would help us to learn together. Now, this is just the starting slide to just let you know the prevalence. And obviously, as you can see, the second point, in India, we do not have still a systemic data, or there is no data on the mental health issues. We know there are few studies in India which are published, and those say this is sketchy data, that 3.8% of population in India identifies themselves as a LGBTIQA plus. So that's the sketchy data we have. In USA, and I shared few of the reports for the prevalence also. In USA, there is a kind of a very systemic data which showed that 4.5% of the population identifies themselves as a LGBTQA, and 39% among them reported to have a mental illness in past 1 year. Now, this 39% transforms in a sheer numbers of a 5.8 million people. And again, this is, we are talking about the US population, which is around, I think, 33-34 million. So what I'm trying to say here is the very high prevalence. If you compare this prevalence with the general population, let me tell you, the general population, the overall mental illness prevalence is around 8 to 9%. So this is almost 5 times more than that. And 39%, and why is that? Obviously, we will come to see, and we will discuss today, and what can be done about it. But just a highlight of this, and the main point here I want to highlight is that the high and very high prevalence of mental health issues among people with LGBTIQA orientation. So I will like to open the discussion now with this case scenario. I will read this out, and then maybe you can share your views, again, your kind of experiences, as I already said. Just before I start sharing, I think these are the case studies taken from my own experience and my own practice. Obviously, the names are changed, and there are no other identifiers. This is a case study of a Sanket, or case scenario, sorry, of a Sanket, who is a 24 years old male. This is very back in 2007 when I met him. He was referred by his family doctor. He presented as a depression, sleeplessness, suicidal thoughts, difficulty at working, workplace. There was no focus, concentration was missing. And because considering severity of symptoms, we, I think, agreed upon to start with the medications. But there was no improvement. Almost for 2 months, I remember he used to come, always visit me every 10 or 12 days, and with similar complaints, same complaints again and again, and there was no recovery. Now finally, after 2.5 months, I remember he shared, taking me into confidence, and about understanding the privacy as well as the confidentiality part of it, he shared about his sexual orientation. So he had understood about his different sexual orientation at the age of 14, 15, and since then he was struggling for self-acceptance, and he was still, obviously there was no cultural support, there was no support from the friends, and he was struggling with that self-acceptance. It was difficult for him to come out to his family and friend, kind of. But I think once we started talking about it, I remember this, and that's why I'm presenting, this case scenario, because there was a, kind of outcome which was very positive after that, and largely because his own support or acceptance to himself, largely, because overall his close friend helped him in this process, and eventually, as I mentioned, his family also, kind of got onto board. They understood the condition, they helped him, and they also accepted it. So I think this is the case scenario to start our discussion. Just like to hear first, obviously, what is your opinion about this? Mainly, what are the causes for his depression? I think that's the main point we should discuss, in line with our today's topic. And obviously, did we able to prevent depression in his kind of a Sanket's case or similar cases, or what could have, Sanket done differently? So I will like you to now maybe take a minute, and then maybe think about it. And sorry, I will just come back to the screen. Yeah. So yeah, please, floor is open. Please try to comment anything, and there is nothing, there is no wrong or there is no right kind of a comment. So you can say whatever you want. Yes.
Dr. Kaustubh, could you please share that case one?
I will.
Maybe some more people while.
Yep. I'll just try to, somehow the can't go back with the same way. Yeah. I'll stay on this case. I think that's a better way rather than coming back to the main screen.
Yes, Rajiv, please.
Dr. Kaustubh. So I agree
Yeah.
with Saloni. Like they have also written in the chat box that Sanket did not have a safe space to talk about his gender identity and sexual orientation. And although I would not say like that was the primary reason, but I think that was kind of like supplementing his symptoms in a way, or like that was not providing him a safe space. So that is why he was suffering from depression, if we are using that term. And when he like confined into a close friend, and when he got a safe space to talk about, he could think about his life in a better way. Like I'm assuming like there won't be any more suicidal ideation or thoughts around the same, because when people are around to accept you, even from my experience, you feel better about going ahead in life and what else you can
Correct.
achieve and how you can get your potential. So I think this is what I would like say about the particular case scenario that you just shared.
Thank you, Rajesh. No, that's very aptly described. I think I will say that's how, kind of this issue basically arises. I agree that, whether you should term this as you said, whether you should term this condition as a depression or not, and that's why I'm going to talk about more and more that really when we are talking about mental health issues among people with different sexual orientation, are we really saying are these classical mental health conditions, or actually, the structural systemic barriers and the cultural family level and all level barriers are actually causing these mental health conditions. So thanks for sharing your experience. uh, yeah, I'm just back. Yeah, any other? Saloni has shared, and I think that's right. But again, my point again is that suppression of the identity or sexual orientation actually in this case is actually, even as you said, root cause for his depression. But that, that suppression happened due to some reasons, and what can be those reasons? That's just explained by Rajesh, but what
Lack
can be
of
those
sex
reasons?
education, Dr. Joe? Is that lack of sex education, which should be imparted at the right age, is one of the reasons for this depression?
Correct, but partly I will say, but again, sexual sex education in even today's world don't kind of don't include people with different sexual orientations or different gender identities. So even if we talk about sex education, it is very typical for the heterosexual people, and does not talk about. So again, in the education, I will say there has to be inclusivity. As much as we are included and as much as we give this information, I agree that at earlier age there will be a high chance that the acceptability will be more. And again, I'm specifically mentioned this year 2007 because at least in my personal experience, I have seen a definitive change over last 15 years or so. When in 2007, the cultural acceptance, family level acceptance, and knowledge about different sexual orientation was very poor and very less, and that has caused a lot of distress. And I can, as we discuss, I'll share few of my other experiences, but that's how it is. Any other one or two thoughts or comments? Otherwise, we can move ahead. Yes, Tanya, please. Oops, sorry, she has left the meeting. Raise that. Okay, there is nothing. I'll go back.
Yeah, I think we can
Yeah,
go.
yeah. How do I sorry, just a technical question. Oh, sorry, Saloni has raised that. Yes, Saloni, please go ahead.
Yes. Am I audible?
Yes,
Yes,
yes, please.
Saloni.
Yes. So I think that another reasons or another causes for this case could be that it was hard for him to accept his gender identity, and there might be some kind of confusion that must be revolving around his sexual orientation.
Yeah, that's right. So, yeah, largely the struggle always, remember from the mental health condition perspective, struggle always start from the level of acceptance, because you see everyone around you practicing or talking about different sexual orientation, which is majority is the heterosexual. That is where the acceptance part or the rejection or you are something different starts coming into your mind, and that's how you start feeling lonely, you start feeling rejected, you start feeling dejected. And then obviously that may if it continues, if you don't have that right kind of a knowledge or a support, then there is a high chance that you will kind of go into a depression. So that's how it is. Okay, let's move ahead. Just a technical question, how do I go back? Can you just still see the slide? You can see my slides, no?
Yes,
Yes,
sir. We
Dr.
can see.
Okay, okay. So I will just go through the second case scenario. This second case scenario, I think again stuck in my mind. This is the first case scenario is from an urban context. This is more of a rural context actually. And I have seen many cases like this. Again, I'm just trying to point out here the difficulties or the barriers people face in their journey or in their life cycle. And again, if you can see again in the first case and now in this case, these barriers are more of a social or cultural barriers rather than actual, issues related to mental health. So this is a case, again, this was, I think, 5-6 years back. Ankur, 28 years old man, his wife, he got married. I think almost after a year, they went to a gynecologist for infertility related issue. Both of them are from rural background. They stay nearby village near Pune. There are all reports, investigations, almost I think repeated investigations came normal, and obviously gynecologist has spoken with them about everything. but they never disclosed. And when after all reports come normal, I think then one of the interview with the gynecologist, Ankur's wife said that their marriage is not non-consummated, and Ankur never showed any interest in the sexual relationship. Ankur said that he suffers from erectile dysfunction. So initially, the gynecologist asked them to go to an endocrinologist for erectile dysfunction. And again, because nothing happened there, endocrinologist then asked referral to a psychiatrist. Uh, and then gynecologist again asked Ankur to refer to me. And that time I think again same way, after 2-3 sessions, Ankur told me about his attraction towards male. He was identified as gay. Somewhere he accepted this in the past. So this is something different, that he accepted that he has the sexual orientation. He had relationships also with men in the past, but unfortunately his family was quite orthodox or conservative, and they never accepted this fact. They got him married forcibly. uh, and again, I never met Ankur after that, so I don't know what was the outcome of this. But this is another case scenario where you can see the difficulty people face. Now again, I'll just try to kind of point out here that why I have presented both the case scenarios with the men having basically the men with the same sexual orientation, because again, unfortunately, in our society, still for females, the lesbian orientation people, not very much acknowledgement or visibility, and that's seen in my practice also. So people who came to me in last 15 years, almost 95% of them are men or gay, as they kind of gay men who came for a mental health counseling or any kind of a mental health issues and so on. But unfortunately, again, females who have lesbian orientation have not came forward. So this is the case scenario. Any opinion if you have, or anything you want to suggest? Again, mainly how what would have Ankur done differently? Maybe that's more valid question here. What do you think, that what kind of a solutions, or what, how did Ankur, kind of try to reduce the barriers what he faced? Yes, Alka, please
Yes,
go ahead.
Alka.
So rather than getting married to someone else, he could have educated his family and his society about his sexual orientation, I think.
Yeah, society is a very large, I think, goal, but at least his family. That's I completely agree that he would have
Yes,
maybe
sir.
waited for a little longer, or he would have just had more resistance. Again, we are not trying to say that what he has done is right or wrong, but this is again a hypothetical situation. If because now I think in a sense he is also stuck, and his wife also is stuck in this marriage. Yeah, Saloni is saying the difference between the two cases is the acceptance of the family. Sanket was accepted, and well, Ankur wasn't. Correct. So that's a good point, Saloni. Thanks. Again, so that's the outcome is different. If you can see, the outcome is different. The journey started for maybe similar for most of the people, but the outcome in case of Sanket, because his family, friends came on a board, supported him. I think the outcome was different, and the outcome for Ankur was completely different. So that's the highlight. Any more comment, or we can again go back? I have one more, I think, and then we will. Any other comment?
I think another thing can be that the idea that once you get married, then things would get better,
Correct.
like the kind of ideas we have around marriage. Like even if like someone is, for instance, someone is alcoholic, then even their family members sometimes marry them to like ensure that after the family, the girl will treat him better or like fix him in that way. So family would fix everything, the marriage would fix everything. So even that kind of idea can lead to like kind of like attention away from what is the issue what is the issue, which was like not accepting his true identity. So that is like the social and the cultural ideas around marriage can also be an impact factor.
Absolutely. Thank you, Rajiv. And this is what we say as a structural barrier. This is how the structural barrier, like a marriage as a system or a systemic barrier, basically causes a problem. And that is the notion of everything will get normal if you get married. And mind you that this kind of advice is not only given by, families or friends, but also, people, professionals do give this kind of advices. So again, I'm not saying the education doesn't have any role here. Basically it's the perspective and the attitude and the approach. How do you see this? But again, as you rightly said, marriage has been taken as a kind of a solution in this case, and that's why I think he got forcibly married thinking that and I suppose here in this case, I never met Ankur's parent, frankly, but I suppose they might be aware about this issue, and or he must have told them, or he must have, as I said, in this case, they know about it, but never accepted this fact. But the point is, again, they must have thought with this notion, as you rightly said, that marriage can solve this problem. And even I think why he was going through the infertility related investigations, because again the notion is once the child comes, or once they both have a child, things will completely go normal. So again, these are the societal or systemic kind of structures which pose these challenges or problems. Yeah. Okay, any other thought?
No, Dr. Kaustubh, I
I
think.
think we can move ahead.
Yes.
Yeah. Thanks. So this is the third case scenario. This is, I think you can see as you read it more about the gender identity and gender dysphoria. This is about Sharda, 24 years old female, been uh, brought by her parents. As she used to dress and groom like a boy, her parents wanted me to treat her as she is very aggressive, always irritable and stubborn. But that all stubbornness, irritability, and aggressiveness was mainly about because she was demanding sex transformation, and she wanted desperately to undergo sex reassignment procedures. Again, yeah, this obviously I understood when I spoke to her. Her dysphoria dates back almost from the age of 14. Fortunately for her, and again, this is a recent case, I think 2017-18, when the knowledge and the talking about gender dysphoria, gender identity disorder was very much common in the media, and there was a lot of access and knowledge in the media about this condition. As well as there is now a lot of knowledge about sex reassignment procedures. There are many professionals now who are supporting in these procedures, and they are kind of, the challenge still is the financial challenge because there is a lot of cost which is involved, but still now the awareness part has increased. So somewhere, kind of a issue here which Sharda is, and I will talk about now the professionals here also, that because this, I was the fifth or sixth professional to which the family members have got her. And the purpose is the same, that we need to do something that should change her mind or change her kind of a stubbornness. Again, this is a very highlight of this case scenario, but in Sharda's case, I know that she struggled, she fought with the family for almost 5-6 years. And for her, I think there was a quite a longish fight. Her education was stopped in between, her mobile was not given to her for a longer period of time, and so on. So there was a lot of fight, but the good thing about, I think, Sharda is she stayed with her kind of a point, and she was very firm about it. And just from the outcome perspective, it's recently last year when I heard from Sharda, she's already started. She kind of collected money, and she started undergoing through the sex reassignment procedures. So that's the kind of a case scenario. Again, any comments about this? It's a different topic in the sense the gender identity and gender dysphoria is a different topic where a lot of again barriers at a family, cultural, and level. Plus, the sex reassignment procedures is another level of a barrier which we still face in our country. So, any thoughts, any experiences, any comments, please?
Sir, I had a question, not necessarily regarding this case, but just in
Sure.
general. I'm a counselor and I've had students coming and telling me about their orientation. Normally they're like, they've accepted it. But once there was a student who was in panic mode and he said, I don't want to be this, do something to change this. So now, you just talked about treatment, or you talked about medical science being advanced. So just a question, what if somebody doesn't want to be what they are? Is it possible to kind of change that also, like through testosterone or hormone therapy or something like that? Would that be a possibility?
You are talking about the gender, transgender
No,
one,
no, like
or the sexual orientation.
orientation.
Yeah, sexual orientation is non-modifiable.
Okay, okay.
So there is a what we called as a very few people identify themselves. Sorry, if you can, I think mute yourself. There is a echo. Thanks. So just I'm making a point here that there are people who identify themselves as a bisexual orientation. So in that case, there is a as we all know about these terminologies, but people who have a one sexual orientation, it's not possible to change from the medical point of view or the scientific point of view. Even from the gender, gender is the same issue. That's
Right.
also the same thing. See, but again, I understand the people who come from this viewpoint about non-acceptance, but again, acceptance is a journey. Again, I'm talking from my clinical or experience which I have seen, but through my clients, obviously, I learned almost all this I have learned from my clients. And I can say that this is a journey. So some people do it, quickly. Some people take many months. Some people do take many years. We have to provide that space to them. And as a professionals, we can keep on supporting and keeping the facts ahead of them. That's how I respond to that question.
Thank you, sir.
Yeah, thanks. Any particular thought about any kind of your own experiences or thoughts around gender identity, gender dysphoria?
Yes, Shivpriya.
Hello, sir. Sir, I am I audible?
Yes.
Sir, I want to just share an experience with one of my juniors. He is actually, I think, uh, my voice is actually echoing. Uh, am I audible now?
Yes, you are now. Go ahead.
Oh, okay, sir. Okay. Uh, So I just want to share my experience with him. He is one of my juniors in our college only, and he said one day that he is attracted towards boys. I didn't ask him whether he's a homo or bi. Then later, after 1 or 2 months, he suddenly came and then told me that, it's not about that I'm attracted towards boys. I'm attracted towards girls also. So I am bi. Then I said, listen, maybe he was somewhere he thought that he should afraid from me, maybe because of that. So later on he was actually a bit confused towards his gender and all, gender and identity somewhere. Then I asked him to read some books, or even I suggested him to join this course. But when I send this email to join this course, he became so anxious, and he uh, started like, no, 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 I don't have any problem, I don't want to join any courses, I don't want to accept myself, I am very normal. I tried to explain him that later on, then I left because I thought maybe he was getting very anxious and conscious, so I thought, let him be. And he started talking to me, even he just now started ignoring me. So I'm quite worried towards him, that I'm even feeling guilty that I should not do this, but can you suggest something, like and what should I do, or how can I help him? Because he has a very he is very introvert type. He didn't talk to much in this college also.
I will say the approach is always may. I think you have gone whenever you heard from him. I think you have done with a good intention in that sense. That's how I put it. I will say, give that space to him. Continue to give that space to him. Many a times people, as I already said, take a lot of time to accept themselves with this different sexual orientation, and largely it's very clear because of the so many discriminative messages around in the society. So many barriers we see from growing up. Even the media nowadays, it's becoming little friendly towards these terms and towards these people. But the portrayal of these characters in the media, as well as the films, the older films, if you know, has always been a problematic. While most of the people, as we know, they have gone through the bullying, and bullying is one of the common, kind of a predictor of the mental health issues. What I will say, what I'm coming to is give that space. He will always come back if you keep on providing that assurance, the privacy and confidentiality maybe to him, and maybe that's not the only issue. You are basically friends, so you can always talk about all other things under the sky besides this issue. So you can always accept. If you accept in that way, I suppose that eventually at some point of time he may kind of come back, or he will accept, and he will come back to you for more help. That's how I put
Okay, so thank you, sir.
it. Yeah.
In this case, Dr. Kaustubh, what I see that the parental acceptance is missing, and somewhere Sharda is convinced she knows about her gender identity, and if she sees that yes, parents are accepting to what she identifies herself, I think that her journey of transformation could be easy.
Absolutely, absolutely. So, gender reassignment procedures, or sex reassignment to be specific, that as a next level challenge, for people, and again for people who orient themselves as a transgender. We know that how their image in the community has built up over these years. So for family to accept people with this gender identity issue, or actually allowing them to go through the sex reassignment procedures, in my experience, I have seen only one or two cases where family accepted them. One of the very, one of the case, very rare case where actually a married female who gone through the sex reassignment procedures after 15 years of marriage, and husband did support her very well. So that was the only one rare case, but most of the cases still I see that acceptance is one case as a person who has a different gender, and the second major barrier, as you said, Professor, is basically for the sex reassignment surgeries. So as yeah, Sukanya, you can go next. Just Saloni has made a point. I will comment on that, and maybe you can go next. Yep, I think the financial part is also important, Saloni, for sure. That if they made little inexpensive, then it might help many people. I completely agree. That's a valid point. But at the same point, I think at the same time, obviously, the perspective and the support from the family is also the important part, because there is a lot of adjustments after the reassignment, and as you all know, I will talk about sex reassignment procedures, but there is a lot, kind of a the time wise also, it's quite a long time kind of procedures which takes place during sex reassignment. Yeah, sorry, Sukanya, go ahead.
Thank you, sir. Am I audible?
Yes, you are.
Uh, just wanted to add one extra point. I mean, I've seen quite a few people, who say things that to, let's say, educate the heterosexual people on queer ideas is not really their responsibility, so to speak. But um, I would say in cases where people are coming out as queer, if they were to share their sources, like how you said that in scenario 3, Sharda, they were aware of certain things about what they were going through, and they were comfortable with it. So if they could share those sources with their family, how they came to know about this condition, how there are many people like this, how it is actually quite normal too, it's not abnormal, and so on, maybe that can help kind of break the stigma. So kind of an empathy from both sides is required, I believe, that way.
Agree. No, completely agree with your point, and that's how I think if we continue to kind of again, it's uh, may, may, points taken, but there is a subjective, kind of changes to every story or every life also, and when unless and until you garner or increase your support, enhance your support, as you said, I think it's very difficult to convince people or change their attitudes. And I think that's a good way, and we will talk about some of these things in the solutions for sure. So maybe let's move ahead. I will try to now, kind of move ahead out of these case scenarios. Obviously, if you have any comments, you can always go back to any of the case scenarios or share your own kind of experiences through the case of in your own life. So, is it visible?
Yes, Dr.
Yeah, yeah,
Kaustubh.
yeah. Thanks. So let's move ahead, and obviously we will have time at the end to have more discussion. Uh, largely, as we know or understand, the causes. Again, this is more to do with from the literature. There is a not a very high level of literature from India. I have shared you with few reports and few organizations who kind of continue to work. Obviously, now in every pocket, largely in urban cities, I know we have organizations who work and do advocacy. And the data is largely from the more of a case scenarios, case series, talking to professionals and so on. And so these are the causes for the mental health conditions. Again, this is not an exhaustive list. There can be a multiple causes. One can add as we go ahead, understanding more nitty-gritties of this problem. I think at a subjective or a personal level, always, as we already discussed, feeling different, which is a common thing. It starts from whenever, as a child or as adolescent, one start identifying themselves, and that impacts the self-identity, because that recognition among the people who are majority of them are different, and you are different from them. That does impact the self-identity somewhere. What you can say, that cultural again impact or a social impact has huge long-term impact on the mental health. So to be very clear, I have many clients still who are in their 40s 50s, who are not still able to accept themselves as they are, and still struggle with a lot of distress around this, a lot of mental health distress, impact on their functioning, not continuously working, having difficulties in sleep occasionally, depression, phases of depression, and so on. So this is very core. What I've understood from a psychological perspective and through my reading and knowledge is this is a very core. Obviously, then the bullying, as I said, is one of the experience which happens very clearly initially in the childhood and adolescency. Bullying, or maybe as we term as a kind of a discrimination, as a form of discrimination, has always carried forward. So it always happens with the young adults in the college, at a workplace also. There is still the discrimination which happens, or bullying as an expression of that discrimination does happen. Stigma and discrimination, we know, at every place, at every level. From a mental health perspective, unfortunately, this stigma and discrimination leads to even discrimination in the health system or the approach of the mental health professionals, which is a very still a tragic scenario after so many years of advocacy and so many years of acceptance of this fact that these all conditions or people with these conditions are completely so-called normal, as you say, though I don't agree with these terms of normal and abnormal. But that's how the discrimination is at the level of even professionals who have trained and educated about these facts. So what happens ultimately is the exclusion and non-acceptance as a person, and there is a lot of feelings of loneliness and left out, or feelings of helplessness, or feelings of worthlessness which creeps in. So these are all, basically I'm trying to say, these are all social cultural reasons for different mental health issues. We will talk specifically about which are these mental health issues. But again, this is the important factor to understand, as we have seen already through the case studies. And we know that there are barriers in accessing education. Again, there are, when I say accessing all these things, is about inclusivity. And there is a lot of exclusion at all these levels of education, job, health services, marriage, as well as justice. So these are the main causes, as you need to understand. There is nothing different, and please always note that there is nothing biological in this at all, which is driving these people more towards mental health issues. So that's not the case at all. Then this is again, it's more of there is in the literature already how things go through the stages of life cycle of somebody who has a different sexual orientation, or a same-sex orientation, or gender, different gender orientation. It's largely the phases of identification, acceptance, when they are in the closet and coming out. So in these different stages, these are the different emotional turmoils when one goes through. Obviously, when you go through this distress, what I'm trying to say, there is a high chance that people may experience depression or anxiety as a condition. Here the terms I'm using as a depression and anxiety more of a feelings, but many of these people can go through, if they don't get a support, if they don't get that required help from their family or friends, then definitely, or lack of knowledge sometimes, many reasons for that can lead to mental health conditions, which we will just see now. See, the common mental health conditions always, as we already said, depression and anxiety disorders. These are the commonest issues what people face, largely logically because of the distress, long-standing distress. There is a high chance that they then go through the depression and anxiety, various anxiety disorders. Suicide, again, that I think you also must be knowing that there is a high prevalence of suicide. Comparatively, the rate for India is around 10 to 11%. And definitely, again, there is no systemic data on this, but as you can see the data in America or US as well as Europe, the rates of suicide are definitely higher than a general population in people, for various reasons we have just already said. A specific condition which is also common with because of many other conditions is a post-traumatic stress disorder. It's one of the anxiety disorder, but again it's a separate condition largely because of the very high level of trauma one goes through in their early childhood or early young adulthood, and that significant trauma or the abuse or discrimination can lead to this kind of a condition. Symptoms largely that of anxiety, sleeplessness, a lot of issues around trust, as well as a lot of anxiety, a lot of feelings of hyper alertness, numbness at the same time. So there is a lot of mixture of symptoms in this disorder. Then sleep-related conditions, insomnia, sleep-related any kind of disorder, largely the insomnia is again common. Substance use disorder is also a very common issue, more than alcohol nowadays, particularly in the urban settings. I have seen many other higher substances to be used. There are many cases that it's not only about because of depression or anxiety or because of these barriers, but many a times I have seen people using substances for getting that identity, and if, for example, if they are going to in the social group with the same sex orientation people, then just to increase their courage to do that, they use substances. Commonly, I have seen in the practice is that before having a sexual activity, same-sex sexual activity, again, in my experience, only have been encountered with the men having sex with men, but again, the same issue that they are consuming substances to go for that sexual activity. So I think this is substance use disorder is again unhidden problem. Not many people are attaching it, but definitely frustration, a lot of other emotional turmoil which people go through definitely increases the substance use disorder. Gender dysphoria is a very specific term which is used even in the medical literature, and gender identity disorder was earlier term, now termed as a gender dysphoria. Largely, gender dysphoria is when somebody identifies themselves as a different of opposite gender, and which causes a lot of distress and frustration for them, which stays for a long, which impacts their day-to-day functioning. It's called as a dysphoria. And this is the condition where one can recommend the sex reassignment surgeries as the solution, which is now kind of a medically valid, that if somebody gets diagnosed with gender dysphoria, then they can undergo through a sex reassignment surgeries, the procedures. So that's the point. Now, talking about, I mean, earlier I was thinking how to provide the solutions or what to talk about the solutions or treatments in this case. I think before solutions, obviously, we need to talk about the barriers in providing the help or providing the treatment or not treatment in a medical sense, but actually a care, a psychological care or psychosocial care to be specific. I think the first barrier is still, unfortunately, is attitude amongst the mental health professionals. So many mental health professionals, it's changing. I'm not trying to say it's the same, which is 10, 12 years back. Definitely, this has changed over a period, but still, I think many mental health professionals still believe the social construct or the cultural construct of sexual orientation and oppose the same-sex orientation or gender-related issues. They still use the biomedical approach, and as I mentioned here, conversion therapy. You must be knowing about conversion therapy, and recently, the Supreme Court also has commented about conversion therapy. The new Mental Health Care Act also opposes clearly the conversion therapy. So conversion therapy, for people who may not know, is the famous word used by largely from a psychiatrist community. So basically treating people who have a same-sex orientation and converting their sexual orientation to a heterosexuality. And many, kind of a medication treatment, electroconvulsive therapies, isolations, torture, and many things have been used from the past till now. There are still multiple, I think last year or last to last year, I don't remember, that it was a case which came out of media, in media basically, about conversion therapy, I think from Kerala, if I'm right. So these are the barriers, I think, in the treatment and approaching also I am talking about. So, finding a gender affirmative or understanding or inclusive mental health professional is also a big barrier or challenge. And now I have come out of the social and the cultural barrier. Here I'm completely talking about the health system and the mental health system or the professional. So these are the barriers even still remains. Fortunately, now over a period of time, through the advocacy of many people and many organizations, now at least the Indian Psychiatric Society, which is the kind of a psychiatric body at the national level, has at least taken this position, have released a position paper on this issue, saying and supporting basically this concept, and saying very clearly that conversion therapy should be stopped, the attitude of mental health professionals should be equal, and there should not be a only purely biomedical approach to people who come with same-sex orientation or different gender orientations, and psychosocial approach needs to be should be given a more weightage. And last point is largely about the general health system. So still we see, and I think if any one of you go or work in the hospital, still we see there is a lot of discrimination and exclusion for people with same-sex orientation or different gender orientation at the health system level. And that's the issue, because many of the accessibility to the health services has a huge issue, and talked about issue for these people. So again, this same, this is attitudinal issue of the health system in general. This is not only for the mental health system, but even the general health system has the similar barrier for the accessing. The last point we have already discussed about this acceptance from family and friends, which is very, very important, and non-acceptance will create a huge barrier. So I think I'm on the last slide now, and then I'll pause for the discussion. See, what I feel, obviously the solution, ideal solution, is how do we change in attitude and approach of mental health professionals. Unfortunately, I think still the curriculum or the training, I'm talking purely from a mental health professional point of view. Curriculum, I think now during the training should include about knowledge of these conditions. You know, should include the aspects perspective building, and that perspective has to be a perspective of equality, equity, and inclusive. And how do you see, and then how do you build your, whether it's a psychologist curriculum or a psychiatrist, how do you have affirmative practices toward this, rather than a very discriminatory practices. So that's I think the important part. And unless and until that starts happening from the training perspective, I don't see the change in attitude and approaches from the mental health professionals in coming decades. To be tell you very clearly, when I got my basically masters in psychiatry not long back in 2002, 3, 4, there was no education around these conditions. There was no though we referred to Western textbooks, obviously it was mentioned that now these are not termed as a mental illnesses, but how do we approach, how should be our approach, how inclusive should be our approach, how perspective should be there about affirmative therapies and so on. So there was no training around this area, unfortunately. And that's why I always say, whatever I learned from the people. I learned, various people, and I think many of these people are there on this course also teaching you or part of your team. But I have learned through these people and their experiences, obviously from clients who came to me and so on. But unfortunately, that training part is missing, which needs to change. So that is one of the important solutions from a mental health professional's point of view, be it a psychiatrist, psychologist, social worker, psychiatric social worker, or so on. Psychosocial approach more than a biomedical approach. I think this is I will say, a very generalized point for everything, but more commonly for mental health, when dealing with mental health issues among people with LGBTIQA plus. I think we have to have more psychosocial approach rather than a biomedical, because as we have already discussed and seen, there is no other biomedical reason for their depression or anxiety or issues, mental health issues or conditions. It's purely psychological and social causes. Obviously, I am not trying to say that when there is a severity or if somebody is suicidal, you may need a treatment for that. I'm not trying to deny that, but the approach, the majority of your approach has to be psychosocial in this case rather than a biomedical. And then again, if that is the case and that is the shift we will have over the next coming years, then I think we can really go down or challenge these notions of conversion therapy. Then people practicing conversion therapies and so on will go down. Affirmative psychological therapies is, again, you must be reading about affirmative psychological therapies. Largely affirmative is basically now it's a step forward basically. So earlier it was more of acceptance and kind of accept how it is and live in the same environment, accept that how this is how the society is, accept that this is how the people around you is, accept the family as it is, and then live your life like this. So that used to be the approach, or maybe the perspective from even mental health professionals back in almost a decade or two back. But now that has to change towards the affirmative. So how do you then encourage people to come out or live life with the respect and dignity, that's the basic rights we have, and then they should also live with that and with the openness basically, rather than feeling ashamed about these conditions, rather than feeling ashamed about their own orientation. So that's how the affirmative therapies should work more and more. Again, the professionals is to get trained themselves on the affirmative therapies. Only knowing about what is affirmative therapy is not going to bring the change or actual support, mental health support to people. Then we have now discussed about this building support through friends, family members is important. Family therapy is an important cornerstone when I talk about the therapy point of view, because as we have already seen how the family becomes the barrier and the cause for mental health conditions. So I think many a times if family is willing, then involving family into the treatment and doing maybe multiple sessions with family till they accept their child is a very very important factor. I think medications, as I already said, if necessary we do use medication. And last point around the gender transformations, the sex reassignments and procedures, which are now again increasing over a last decade or so, has been increased. There are more professionals who are coming out. So there are two forms of reassignment surgeries which we or procedures. We have largely there is one hormonal replacement therapy which goes on for 6 months or more, sometimes a year, and then a person should go for a sex reassignment procedures. Again, the sex reassignment procedures are multiple. It's not only in one surgery, and that can take up to 6 to 9 months more. So all in all, that's how we already discussed about the financial implications of all this. And as I earlier said, the duration of it. So it does take 2 to 3 years after the decision has been made to get into the sex reassignment, actually starting the procedure and completing the procedure. And obviously then there are legalities, changing the name and everything. These are the other legalities to follow, and plus obviously then adjusting with the society and the family and so on. So it's the long journey. What I'm trying to say is the long journey. It's not the easy thing of making a decision, executing this decision, actually going through the hormonal replacement, then going through the sex reassignment and so on. So again, that's how the gender dysphoria has been termed a condition now, or gender identity disorder is basically needs to be proven if one has to go for sex reassignment procedure. So that's the, I think the last in my viewpoint is that from my point of view, what I want to share with all of you. Now happy to hold here and go back to if there are some questions around this, or you have any, again, your own views, points to be made, experiences, please. We have, I think, another almost 30-40 minutes. Yeah, Rajiv has raised hand. Rajiv,
Oh,
please.
so like of all the solutions that you've talked about, so we also have the Mental Health Act in our country. So, are you aware of like if the act incorporates these solutions or the kind of way the act looks at mental health specifically for like members of the LGBTQIA plus community?
Yes. So I have not included law and policy here because I always thought because the course is a quite wide and the curriculum will include kind of a law and policy perspectives. But thanks for this question. Definitely, the Mental Health Care Act, in fact, includes everything and actually promotes the rights based approach for everyone and does not discriminate at all. So Mental Health Care Act, for everyone's knowledge, is based on the United Nations principles on Convention on Rights for People with Disability. So it takes the same paradigm or same perspective. And in fact, that's where I said that recently when the Mental Health Care Act came out in 2017, there was a judgment, Supreme Court judgment, on the basis of Mental Health Care Act. They have basically opposed the conversion therapy in the LGBTIQ. And I think I'm not getting that case, but MHCA got mentioned twice in relation to the LGBTIQ and how MHCA, Mental Health Care Act, when I say MHCA, actually supports the inclusion of people with LGBTIQ orientation. Yeah, so I think now the act is also there. So all the professional side issues like from the treatment, conversion therapy, everything can be opposed or challenged through the Mental Health Care Act. If that answers your question. Yeah, thanks.
Yes, sir, definitely.
Thank you. So any other thought, any experiences, any question? Any questions or any, anything which maybe I have not covered also, and if you want to ask, please, any question in your mind. Yes, you can mention in the chat also. So largely from a, I will just talk more till you maybe think about your question. I will try to formulate. See, from a professional perspective, what I have understood, as I already said, that the problem is already in the training, which needs to be, I think, revised, and we need to have this additional another way of, we always say that being inclusiveness is always, to have actually, even in the faculty, for example, or in the main, people with lived experiences, as we say, so people who have LGBT orientation, including them as a faculty members many a times in these curriculums may change the perspective or the attitudes of people. That can be a possibility. So I don't know if you may. I have shared few of the readings of Ketki Ranade. She works at a Tata Institute of Social Sciences, have worked extensively in last 2 decades, uh, uh, as well as did a lot of research around this. So maybe you can read her readings also, but her papers, as well as she has published a book also around the journey of queer people. So my point is this training part. I think more and more we kind of invest in the training part. Largely, again, I'm talking about the professional point of view. The earlier point made by professor about the child and the sex education is also valid, but from a professional point of view, I think it is very, very important that we thrust upon training, try to change the educational pattern, what messaging we are giving basically, and how do you actually build this perspective. Because I remember during the 377 verdict, and before that verdict, actually there was a drive to file affidavit in affidavit for basically squashing the article 377, and that affidavit has to be submitted by a psychiatrist, and there was one of the organization in Maharashtra who was working for that. And unfortunately, across Maharashtra, only 5 psychiatrists signed the affidavit. There are almost 2,000 psychiatrists in Maharashtra. Only 5 psychiatrists signed the affidavit, and this I'm talking about 5-6 years old fact. So I think that's how the change in the training is the only way now we can bring the attitudinal change among the professional. That's what one of the part. Obviously, we have to continue to advocate among current existing professionals and how we can make them more kind of accepted, inclusive about this issue. Yep, sorry, I will just hold on. There is one question from Shivapriya. Being a psychiatrist, you may also feel sometimes stress. How do you deal with them? This is okay. That's a longish question. Okay, I will come back to Rajiv's question. So I think Shivapriya, so I think maybe a general question, but this is the professional, every profession has their own hazard. Every profession has a stress as a hazard, I will say. So our profession is not kind of different from that. What I think the same measures basically. I think I think you should limit your you should limit your work. That means you have to balance your life basically. So you prioritize what you want. So you're in my case, my practice. So I do actually multiple things. So I'm in the research also, as in my introductions you must have read. I work as a research fellow at the Center for Mental Health Law and Policy. We do work on community-based mental health projects and programs, work in the different sectors, plus I do practice. But then again, there is a life balance. That means you give time to your family, you give time to your own personal choice, hobbies and so on. And plus then small things is taking a breaks. So regular breaks is an important factor, I always feel. Again, this is, I'm talking from the personal point of view. Self-care, always remember, is a tailor-made approach. So you have to make your own self-care techniques or a self-care routine. But small breaks is important. A little longish break every 3 months, once a year, a more longer break. So this breaks is very important to stop the burnout or the stress, and obviously for your motivation, because otherwise life will become, or any work can become monotonous, because you continue to see the same thing again and again. There is a high possibility that monotonicity can build in. So these are the few techniques, I think: the balancing your life, priority and time management, and taking these breaks. That's how I will say. As you said, beyond, if I am right, apart from meditation. Yes, so that's these are the points I will say. Just go through the Rajiv's comment. He's saying, also like the way you took the class. Thanks. Thank you, Rajiv. I remember in one of the class on mental health, the teacher posted a case study with the question, what is wrong with this person, this narration, this language of wrong offensive? Yes, absolutely. 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 So absolutely. So language, I think, is important part. In fact, here language, makes in mental health in general. We again, what is missing from our education is the language part. And typically, still from a mental illness point of view, if that people still term somebody who has a schizophrenia as a schizophrenic, and that's the wrong language to have. Actually, that's a very derogatory language in that sense. So person always comes first, and then his condition or any issues comes. You can't say if somebody has a schizophrenia, that doesn't mean they should be labeled as a schizophrenic. And then why the language is important, because then this term schizophrenic then becomes popular even in the media and general terminology. And a lot of stigma, if you read about stigma in mental health, or stigma in general about any other discriminating factors, be it caste, race or anything. I think language is a very important. So it's a valid point. And in fact, if you have gone through when I saw the topic, and I thought, when we talk about the mental health issues, so again you have to say issues or conditions here, because frankly, a mental illness is a very derogatory term, but more so with people who have LGBTQ or QA orientation or queer people. I think all the mental health issues for them is largely, which are more than a general population. So if general population has a prevalence of 8 to 10%, and if they have 30 to 40% of mental health issues, prevalence of mental health issues, that is largely because of these all barriers what we have seen. There is no other reason. If we don't have these systemic and structural barriers, these attitudinal barriers, that prevalence will be same as other people. Why should and that's again the point about discrimination or stigma about these people. So yeah, so I think thanks for that point. Yes.
And I think language is the only vital part of human connection. That's how you connect, right? That if you're able to communicate well, people can connect very well.
Absolutely, thanks. Absolutely, and in my experience also, now when I have understood why, without any, frankly, without any particular training, that how to do this affirmative therapy or how to have this approach, I think it was the language, which fortunately again I say thanks to my postgraduate teachers who definitely taught me about the language and how do you use language and why language is important. I think, and that I think opened my own mind, and kind of then I could, then with the further reading and knowledge, I could change my perspective, or can have this perspective in that sense, and then build on that rather than saying, because to be very frank and open in this forum, that I also faced a lot of discrimination among psychiatrists when I started seeing clients with different sexual orientation. But that's the reality. You can't you have to stick to your agenda basically. Yeah, so that's just I wanted to share. But that did happen, and that's again, there is a change now. It did happen initially in the years 2008, 9, 10, 11, 12 almost, 4 5 years, but now things are changing. So definitely, I think the media exposure overall is changing some of the attitudes and mindsets of professionals. Yep. Any other comments, questions, please? Any doubt you have or anything? Yes, yes, Shubham, please go ahead.
Yeah, sir, am I audible? Hello?
Yes,
Yes.
yes, Shubham.
Okay, this my question is that, I mean, if a person of say alternative sexuality, if he gets married and sort of tells his wife about, I mean, would be wife about this orientation prior to the marriage, I mean, how far could the marriage be feasible?
So when you say marriage is feasible in what language? Do you see from a kind of a reproduction point of view? You are saying the marriage or compatibility point of view?
No, I'm talking about the compatibility factor.
So compatibility is always subjective. So means I remember again in the old days when there was a huge community resistance around these issues, and I know still there are people who have kind of a married for the sake of the society, understanding and knowing that this is a sexual orientation they have and it is not going to change. In many of these cases, they have told their partner beforehand, and again they have been kind of a living life together. The problem is always going to be about emotional compatibility that won't be able to develop because of obvious reasons, and the physical compatibility. So that when I say emotional, as in the attraction part, I'm talking about the romantic attraction. Other emotional compatibility, like a friend, you can always have, but obviously that compatibility will have, there will be some frictions which will happen. But in my again experience, and again this I will always say, these are subjective choices, means there is nothing right or wrong in this case. But I have seen many people taking this choice, that telling their partner beforehand and going ahead with the marriages and living kind of in the married life for the social and family reasons. But this can't be generalized, obviously, and this should not be the this can't be the solution, I'm saying. This is
Yeah, exactly.
open by.
Sir, I mean, if we just kind of look at it from the ethical point of view, I mean, how far can this be, I mean, quote unquote, ethical or moral to get married and having with, I mean,
See,
alternative
yeah.
sexual orientation?
Without knowledge, though, it's completely unethical for sure. With knowledge, also the ethicality is question mark, because unless and until you stay together, you don't understand exactly. And because the notions about this sexual orientation are still that these things can be changed, so this notion is always dominant. So obviously, that ethicality is a question mark. Uh, but again, these are the subjective choices, frankly. So there are no other explanation to this. In my only experience, again, this is purely an experience. I know one couple like this who have married and kind of a married for almost last 10, 12 years now. So that's the only one example I have. But again, as you rightly said, the ethicality is a question.
Thank
But
you, sir. Thank you so much.
Sir, have you ever come across any couple wherein after marriage the wife or the husband came to know about the sexual orientation of the other partner, and he or she or they, uh, whether they supported each other or they helped each other and came out very positively out of that relationship?
uh, Can't recollect. There are one or two examples faintly I can remember where there was a kind of a positive outcome, as you are saying. Uh, Most of them are, I think, it's a very difficult situation. But few of them, one or two I remember. Only one very clear case, as I already I think shared in passing, is about this person who has a transgender from transgender different. She was a female and having gender dysphoria for almost 20 years. And at the age of 40, 42, 43, her husband supported her to accept that condition, as well as not only accept but actually then transform or do the sex reassignment procedures. And now, in fact, that person works for advocacy for this population. So that's how the supportive family was. So that's the very stark example in my mind.
So was that the family had awareness, or after any counseling or seeking mental
So
health professional help them to came out positively and the support?
so there was a mental health professional help, but largely driven by the person themselves. I think driven that the husband was very supportive. In fact, they have a kids also, so the kids were very supportive in all this
Wow.
process, and they really supported her to go through this kind of a transformation. So that's a very unique example in my mind. It's very difficult to have that kind of example, but that's true. That's how the reality is. That's how the examples are also. So it's not like you can't
Absolutely.
have a one rule for
Yeah.
everything. Yeah. But most of the cases, unfortunately, do suffer. Means most of the cases, still we are talking about sexual orientation. We know that. I know personally, in my own clinical experience, I know 5 to 6 divorces happen due to this reason, where there is no disclosure of the sexual orientation. So it's one of the most common, one of the commonest reason, I believe. It will never come forward as the reason, even in the court of law, but that's the common reason. Typically I have seen many people or many couples who come after 3 to 4 years of marriage, and it's a non-consumed marriage. There is no sexual relationship between them of 3 4 years. That's the very classical presentation that one of the partner is actually not having a different sexual orientation. It's one of the presentation. I'm not saying that's the only reason, but that's how it works. And still people stay in the marriage for a long, suffer and so on. But yeah, so those are my few of experiences.
And in such marriages, is the family court has any provision for mental health professionals? Do they refer the cases to the mental health professionals, or do they have already in their family court any mental health professionals that they have hired, because everything is within the camera? I mean, it's very, I mean, it has to be, you can say, transparent.
Yeah. So family courts do have a counselors for sure. So they do refer the cases to the counseling. But my only point was, I don't think when people with this kind of issues go to court, they actually put forward this as a condition. Very few people have really said that this is a condition. For example, typically a male saying that because I am a homosexual, the divorce is happening. I don't think nobody will disclose this information. So, but yes, there is a counselor. There might be some cases who get referred to the counselor for sure. But
But the counselor, there are many counselors. I'm sorry to say this thing here. I have seen many counselors, even as you also mentioned that earlier. Medical health professionals, they were not ready to accept the fact. So the same way, even the counselors I have come across, that they say नहीं, ये सब दिमाग का खेल है, या ये सब western influence है. So unless they are aware, unless the counselor which is hired by the family court has that much of awareness, I think that person can also misjudge, or can
yes,
mishandle other way,
absolutely. No, completely agreed. I think it's not about counselors. I think I can say psychiatrist, and psychiatrist community also knows this,
yes,
that there is a 90% still people in psychiatrists don't treat or don't have this basically this simple principle of basic human rights, that everyone is equal. I think that notion is not there. And even now, it's a very contradictory fact. All the psychiatrists do follow, let's say, the international classification of diseases, or they follow what is called as the Diagnostic and Statistical Manual by American Psychiatric Association. Now, American Psychiatric Association has taken this stance from 1980 or 70 almost, that the homosexuality is completely normal and it is not a mental health condition, and please do not treat it as a mental illness. The contradiction is they will follow all this that is in the DSM to their core from the diagnosis perspective, but they will ignore this fact what they have mentioned. That's how the that's unfortunate, but that's how the source. I'm not trying to blame anyone here, but the problem is twofold. I think one is the social influence as they go through, and the second important point is the training. I think that we lack. There is no training around these issues at all. Still the training in the psychiatry or psychology. I don't think any inclusion of these topics there.
True. Rajiv has raised.
Yeah.
Yeah, Rajiv, go ahead.
Yes, sir. So, while I do agree that there are some counselors and psychiatrists who have been very helpful for me, but from the personal experience, I also wanted to share like two incidents where, I did not receive the kind of help that I was expecting. So, once a psychiatrist, when I told him about like being gay or being queer, then he told me like, tell to your family that you're bisexual so that they will feel ki you are attracted toward girls also. And another one told me that you are gay because you have attraction towards men, because you have some unresolved tension with your father. So go have the conversation with him and things would get in line for you, like you will become straight and everything. So I do feel like from my experiences, like things are not like there is a need of sensitivity, but at the same time, these are also like 4 to 5 years ago. And since then, there has been so much conversation regarding mental health and especially therapy. And even for me, I have there's specific term queer affirmative therapy, which was not very much prevalent earlier. So I think in that way, things have improved a lot as well.
Thank you, Raju, sharing for your personal experience. I completely agree with you, man. There are these classical examples, even in my experience also. I forgot to share one thing also that, and this is again the notion from the psychiatrist, and psychiatrists do tell different theories, psychological theories for people who are, gay or different sexual orientation. One of the theory also I have heard, and it takes a lot of time to convince people that there is no connection with that, is the theory around having, going through a child sexual abuse and then transforming into different sexual orientation. So this is, I have seen a very common theory put forward by a psychiatrist. Nowhere in literature it is written. That is their own theory, and then they try to, convince that person that is why you have this homosexuality. And you can then obviously do the whatever the medications and other part for the conversion therapy. So that's another fact, as you also explained, Raju. But, yeah, so unfortunate, but yes, I completely agree. The positive scenario, there's nothing. Things are changing fast, particularly among the psychologists. I think things are changing very fast. As you said, that queer affirmative therapy has becoming more and more prevalent. Many celebrities are coming out now. There are pictures are changing. Many people are now openly talking about this. Media is highlighting and more sensitive about this. Earlier media, if you see 20 years back, it was more about again discrimination, and the terms used to be very derogatory. So now things are definitely changing. Psychiatrist, so psychologist, I always believe psychologist will change, but psychiatrists will take time to change, because unfortunately again they are trained too much into the biomedical approach. My always debate with the psychiatrist is, even if you are trained on biomedical approach, if you do follow the, let's say, American psychiatric guidelines or international guidelines, then they say that this is not an illness and you should treat them as a inclusive or through the psychosocial approach. But that's how it is. So these are few points. Yep. Okay.
Any more questions?
You had Bindu Madhav Khire also talking
Yes,
on this topic.
yes, yes, Dr. Kaustubh. We have two sessions with Bindu Madhav Khire sir. Have you
So
worked with
Bindu,
him?
yeah, very closely. He's a good friend. So
Okay,
yeah,
okay,
yeah, works with Bindu since the start. Since Dr. Bhushan Shukla and Bindu are quite work closely.
okay.
Yeah, Bindu I know from 2006-7. So
Wow.
since I came back to Pune, yeah. Yeah, so Bindu basically does a lot of advocacy. I have heard me kind of said his name because he largely do the advocacy work, but he's very helpful with the resources also. That's what I,
Yes,
he tries to, then obviously on this mental health professional perspective, I again got his name because he does push, connect with IPS, Indian Psychiatric Society, goes to the psychiatric conferences, try to sensitize psychiatrists. So he does a lot of work in sensitizing professionals basically.
absolutely. So I think
We can
there are no more questions.
Good.
Over to Shivani, my colleague. Uh, Shivani, I will just give the vote of thanks to all of you. I hope I'm audible.
Yes.
Yes. So when we talk about the problems that the community faces, one of the most important ones are the struggles that they internalize and which of course reflect in their personal lives and their professional lives. So when we talk about alternate sexualities, mental health is a very important aspect. We discussed that at length yesterday with Dr. Anaga, and thank you, sir, today for taking it forward as well. You have been really interactive with our participants, patiently answered all their questions, even discussed so many case studies, which helped us get some perspective from a counselor's side. So thank you so much, sir, for taking out time from your schedule and coming and talking to our participants virtually today. It was a privilege to have you among us today. Thank you so much, sir.
Thank you. Thank you, Professor Renu. Thank you, Shivani. Thank you for
Thank
inviting
you
us.
very much, sir.
Thank you all for listening patiently. So that's quite a long session.
Thank you, sir.
Okay. Thank you. Bye bye. Take care.